In laparoscopic living donor nephrectomy, first described in 1995, the left kidney has remained the preferred organ of choice due to the greater renal vessel length. Anatomically, the right renal vein is considerably shorter than the left, and the right artery lays partly retrocaval. Even if laparoscopy has decreased the access-related trauma and morbidity and enabled fast recovery and discharge, the evaluation process for the kidney extraction must follow the principle that the best kidney should always remain with the donor, independently from the surgical technique. Several solutions have been suggested to overcome the technical challenge of short right renal vein, and assisted laparoscopic donor nephrectomy permits to combine the necessary extraction incision to manually assist the procedure in dissection, preventing torsion of the kidney after lateral attachments, dissection, and performing an easier hemostasis by manual compression. In our transplantation center, regardless of the site, hand-assisted laparoscopic donor nephrectomy is the method of choice for donor nephrectomy since December 2003. We describe in this video the right side hand-assisted laparoscopic donor nephrectomy with hand-assisted extension of the renal vessel, technique that allowed the exposure of the right aortorenal junction and provide maximal length of the right renal vessel. With the donor in the left flank position, the cavity is explored using a 5-port transperitoneal approach, 11 mm umbilical port for the laparoscope, one 5 mm port for the liver retraction, and one 5 mm to 10 mm trocar as working ports. After superior retraction of the liver, the peritoneum is opened laterocolically and the colon mobilized. It followed the inspection and suspicion of psoas muscle and ureter. Preparation along the ureter and the gonadal vessels to the renal hilum. After complete exposure of the kidney and vessels with ligation of the side branches of the renal vein, the vena cava and the aorta are isolated. The kidney is dissected until it is only fixed by the hilar vessels. At this stage, full mobilization of the right renal pedicle and inferior vena cava is possible. The renal vein is dissected down to its throat from the cava, and the renal artery mobilized just to the lateral border of cava to obtain a sufficient length for the anastomosis. The residual nervous and connective tissue between the artery and the vein are then dissected carefully. Thereafter, the left hand of the surgeon is placed intra-abdominally via a lower-pararectalincision. The vessels are further preparated under digital control. Then, using the index and the middle finger, the cava is mobilized and pushed aside. After intravenous administration of heparin, the ureter is cut at level of pelvis minor. The vein is accordingly held between two fingers, index and thumb, and closed by a triple-row Endo-TA stapler. The same procedure followed for the artery. This simple maneuver results in recovery of the entire length of right artery, making a safe and simple anastomosis possible. In a prospective study, we compared 51 right and 40 left-sided hand-assisted laparoscopic donor nephrectomy. The mean procedure time was 123 minutes versus 135 minutes for the left procedure. The mean worm ischemia time was 45 versus 41 seconds in left procedure. There were no conversions. Mean blood loss was 92 versus 101 ml in left procedure. Delayed graft function occurred in two recipients, one in the left group and the other in the right one. 1 year graft survival rate was 97.5 in the left versus 98.1% in the right group. No significant difference in serum creatinine values was seen between the groups. In conclusion, right hand-assisted laparoscopic donor nephrectomy is as safe and feasible as the left one, and assistance results in a convenient length of right renal vessel without an increased incidence of vascular thrombosis.